Hello and welcome to our webinar, Let's Work Together, Healthcare for the Homeless and Continuum of Care Collaborations. My name is Melissa Da Silva and I will be moderating today's webinar, which is a production of the National Healthcare for the Homeless Council made possible by a grant from the Health Resources and Services Administration, Bureau of Primary Healthcare, and a special thanks to USIC for participating. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. At any time during the presentation, you may type your questions for our presenters in the chat box below the presentation slides. Questions will be answered at the end of the presentation during the Q&A session for about 10 or 15 minutes or so. This webinar will be archived on our website within 3 business days with attachments and links to resources. If you're experiencing technical issues, please call Victoria at 615-226-2292. Thank you all again for joining us today. We have 3 amazing presenters. Our first presenter is Richard Cho. Richard is a policy director at the United States Interagency Council on Homelessness. He facilitates and coordinates the interagency priorities on ending chronic homelessness by 2015, among many other duties. Prior to joining USIC, Richard spent 12 years working at the Corporation for Supportive Housing, where he advanced supportive housing innovations for vulnerable populations. Richard's presentation today will lead us into the content with a high-level or national perspective on HCH and CoC engagement with the Federal Strategic Plan to End Homelessness. And we're so happy that he's able to join us today. Following Richard will be one of our own, Mr. Joe Ferguson. Joe is the Executive Director of Advantage Health Centers in Detroit, Michigan, and has been so since 2008. He also serves in numerous leadership roles in Michigan, too many to name right now, but of important for today is his service as a board member of the Homeless Action Network of Detroit, the CoC. He is also on the planning committee of the National Healthcare for the Homeless Council. Our last but not least presenter for today is Ms. Cindy Crain. Cindy has served over 6 years as the first executive director of the Tarrant County Homeless Coalition, and she in Fort Worth, Arlington, Tarrant County, Texas, Continuum of Care. She has a ton of experience in homeless management information systems, working on consolidated plans, you name it, she's done it. She is now in the midst of restructuring the CoC board in response to the HEARTH Act interim rule and planning for implementation of a coordinated and centralized intake and assessment process. Ooh, that was a mouthful. So with that, I would like to turn the virtual mic over to our first presenter, Mr. Richard Cho, to begin this presentation. Thank you, Richard.
Great. Thank you very much, Melissa, and thanks to the National Healthcare for the Homeless Coalition for asking me to present, and thanks to my co-presenters. I'm very excited to be part of this webinar and to be talking about this very important topic, which is, I think, really about trying to identify some concrete ways that we can strengthen the integration between health and homeless services and housing to achieve our shared goal of ending homelessness. The overview of my presentation includes just a little bit of framing around the issues related to homelessness and health crises. And then second, I'll talk a little bit about our federal strategic plan to prevent and end homelessness, otherwise known as Opening Doors. And then I'll talk about some of the potential roles that Healthcare for the Homeless clinics can have in Opening Doors. And lastly, talk a little bit about what can be done to strengthen partnerships between Healthcare for the Homeless, Continuums of Care, and community efforts to end homelessness. So just to begin, I think as many of the people participating in this webinar will know that there's a high prevalence of chronic health conditions among people experiencing homelessness. I think national studies have found that approximately half of homeless persons are reported to have mental health issues, many who have more serious and persistent mental illnesses, including chronic depression, schizophrenia, personality disorders, bipolar disorder. There's also high rates of alcohol and drug use among people experiencing homelessness. And also, and I think this is no surprise to people who work in healthcare for the homeless, that there's high rates of chronic physical health problems, infectious disease, as well as other chronic conditions. I think what we've also found is that there's a number of studies that have found that experience of homelessness is also associated with a higher risk of mortality and shortened lifespans. There have been some studies that have found that people experiencing homelessness have life expectancies that compare to some of the toughest places in the world in sub-Saharan Africa and Afghanistan. That basically means that in one of the wealthiest countries in the world, we have a subpopulation of people who have extremely poor outlooks because of their health needs, which are exacerbated by homelessness. We have also known for some time that people experiencing homelessness often are forced to utilize some of the most expensive types of health services because of their lack of connection to a healthcare system and network. That some studies have found that people experiencing homelessness spend 4 days longer per hospital visit than people who are non-homeless, who have otherwise comparable characteristics. And that results in additional costs, something on the order of $2,400 per each hospitalization. Studies around the country, including in Hawaii, have found that people experiencing homelessness have high rates of hospitalizations, and which translates to high admission costs. And in one study in Los Angeles, which is where this bar graph comes from, this was done by an organization called the Economic Roundtable, they found a subset of homeless individuals who really were quote-unquote super utilizers, who used on average about $6,000 per month in crisis, community, and correctional healthcare services. So the cost, I think, of the health crisis among people experiencing homelessness is experienced both in terms of human terms as well as in fiscal terms as well. I wanted to also emphasize that in addition to looking at just healthcare, I think wanted to emphasize the importance of housing in helping to address healthcare. These are some of my favorite quotes that really try to speak to the importance of housing in addressing health needs. The first comes from the Robert Wood Johnson Foundation, and one of their taglines is that health starts and is sustained where we live, work, play, learn, and play. Another comes from a study that was done in New York City of a subset of individuals who were super utilizers of emergency departments, and essentially this quote comes from that policy brief that states that the recognition of the complex care needs and fragile social circumstances of these especially high-need patients has stimulated fresh thinking about aggressive outreach, intense coordination of services by integrated care teams, and the need for non-medical resources such as supportive housing, all of which could help curb the cost of health care. And last but not least, this quote comes from Josh Bamberger, who is the medical director at the San Francisco Department of Public Health, works on homelessness issues there. And he essentially was quoted in a magazine article that providing health care for the homeless without housing is like shooting an elephant with a BB gun. My point is that housing should be a health care intervention. I think that really underscores the topic for today, which is how can we strengthen healthcare for the homeless partnerships with Continuums of Care and with efforts that are trying to deliver housing, and particularly permanent supportive housing, to people experiencing homelessness. Permanent supportive housing as an intervention which combines deeply subsidized affordable housing with access and linkages to really intensive health and social services have been really documented to show that they have dramatic impacts both on health outcomes as well as on healthcare costs. A Denver study found that about 50% of tenants placed in supportive housing had improved health status, 43% had improved mental health outcomes, and 15% had reduced substance use. A study in Seattle had found that there were pretty significant reductions in alcohol use among people who had chronic alcohol addiction once placed into permanent supportive housing. And a couple of studies now have found that for people living with HIV and AIDS who've been placed into permanent supportive housing, that they have significantly higher survival rates, lower viral loads, and higher T-cell counts compared to control groups. And all of that, I think, translates to the impact on healthcare costs by reducing people's use of emergency departments, reducing their inpatient hospitalizations, and involvement in other crisis health services. That all translates to lower potential costs. And some studies have found that supportive housing has been associated with a 41 to 67% decrease in Medicaid costs among people experiencing homelessness. So I wanted to turn now to Opening Doors, the federal strategic plan to end homelessness. There are two kind of key taglines related to Opening Doors, and one is that no one should experience homelessness, and that no one should be without a safe, stable place to call home. The Opening Doors has 4 federal goals, and the first is that we would finish the job of ending chronic homelessness by 2015, and that we prevent and end homelessness among veterans by 2015. Third, that we would prevent and end homelessness for families, youth, and children by the year 2020, and that we would set a path for ending all types of homelessness. There are 5 themes within Opening Doors. The first is to increase leadership, collaboration, and civic engagement. The second is to increase access to stable and affordable housing. The third is to increase economic security of people experiencing homelessness. And the last 2, which I think are probably the most relevant here, are to improve health and stability among people experiencing homelessness and to retool the homeless crisis response system. And I'll talk a little bit about what roles healthcare for the homeless can play in those latter 2 goals. I wanted to talk a little about the Continuums of Care, which, as many of you know, are the local collaborative bodies that govern the use of HUD's homeless assistance grants, sometimes known as McKinney-Vento funds or Continuum of Care funds. These are really collaborations between both nonprofit and public sector organizations. They often work in partnership with state or local interagency councils on homelessness. And what they essentially do is in addition to managing how HUD homeless assistance grants are used, they also support and help manage the inventory of housing and services to end homelessness, which includes, I think, permanent supportive housing. Now, as I mentioned already, permanent supportive housing is intended for people experiencing chronic homelessness with the longest and most persistent experiences of homelessness, and those who also have disabilities or disabling conditions and chronic health conditions. I think Continuum of Care, as really the network of organizations that provide homeless assistance and permanent housing for people experiencing homelessness, that they have a number of challenges in actually reaching people experiencing chronic homelessness. The first is that in many communities, permanent supportive housing providers remain disconnected from homeless outreach and crisis response systems. That integration, I know, is improving in many places and is strong in some communities, but that by and large, housing often works in a silo from some of the homeless outreach and crisis response systems. Second is that there's often a lack of systematic approaches that Continuums of Care and communities have for identifying and finding and prioritizing the highest need cases, people who have the most severe health challenges. Continuums of Care also have challenges in obtaining verification or documentation of the qualifying disabling conditions in order to be eligible for HUD-funded permanent supportive housing. An individual needs to have a disabling condition, and often the homeless outreach systems and crisis response systems have a difficult time verifying that the individual does have those disabling conditions to make them eligible for permanent supportive housing. And the other challenge, I think, is that permanent supportive housing does not always have access to quality wraparound primary and behavioral health care. I think the experience has been that the way to fund the services connected to housing has been often piecemeal and fragmented, that there haven't been a single kind of dedicated source of funds to be able to provide those quality services supports. Unless I think discharge from hospitals and crisis health settings is often mistimed with the availability of permanent housing, that often hospitals and healthcare settings are in need of trying to find housing for people immediately, whereas permanent housing options often have long waiting lists or may take a long time before they become available. So given those challenges, I think there's a number of ways that healthcare for the homeless can play a role in helping address some of those challenges. First, looking at the theme around retooling the crisis response system within Opening Doors, which calls for transforming homeless services to crisis response systems to prevent homelessness and rapidly return people to housing. There are 3 particular strategies that are identified under that priority, which I think are places where healthcare for the homeless can be of assistance. The first is around collaborative outreach to street and homeless services to identify high-priority individuals experiencing homelessness and connect them to housing. And I think healthcare for the homeless, as a critical part of homeless outreach, can play a role in helping identify those high-need individuals. I think including through sharing data among to know the people who have the most severe health challenges, and then having a role in making referrals to housing. Second, Opening Doors also has a strategy of facilitating permanent housing access and entry by clarifying eligibility and providing documentation of qualifying disabilities. And that's another place where I think healthcare for the homeless can help individuals obtain benefits and health insurance. And I think through the Affordable Care Act, the expansion of Medicaid coverage creates a new opportunity and a role for healthcare for the homeless to help encourage enrollment into Medicaid and other health insurance for people who qualify for that. And they can also provide the documentation of the disability status and the disabling conditions that will qualify people for permanent housing and services. Third, Opening Doors calls for utilizing mainstream resources to provide housing stabilization assistance. and healthcare for the homeless, which often draws upon mainstream resources, namely Medicaid and health coverage payment systems, can also provide care management and care coordination to help facilitate that transition from homelessness to housing. And so as as part of the mainstream health system, healthcare for the homeless can really help bridge from homelessness to housing. In terms of the theme around improving health and stability, which calls for the integration of primary and behavioral health care services with homeless assistance programs and housing, there are three strategies that I think also create an opportunity for healthcare for the homeless to contribute. One is around that the health and housing provider form partnerships to co-locate healthcare with housing where appropriate. And I think healthcare for the homeless can certainly deliver health services or establish satellite clinics within or near permanent supportive housing, and certainly that's something we've seen around the country where healthcare for the homeless are able to station a part-time satellite clinic within permanent housing or even in emergency shelters, or to station their mobile services to have access for people who are living in permanent supportive housing who are formerly homeless. They can also establish health homes to provide coordinated and comprehensive health care to people with complex health needs. And I think there's been a lot of work happening around the creation of health homes and kind of coordinated networks of healthcare services. I think where healthcare for the homeless can enter into and form partnerships with other providers to establish those health homes and really be able to provide really coordinated and wraparound care for people experiencing homelessness. Opening Doors also calls for establishing medical respite programs to help transition people from hospital discharge to permanent supportive housing where people are not kind of medically able to move directly into permanent housing. And I think healthcare for the homeless can also create and operate medical respite programs to prevent that discharge from streets and, again, create that bridge to housing. In the next chart, this is a really just cute illustrative way to show how healthcare for the homeless can really bridge from homelessness to housing. Healthcare for the homeless, which is represented by this mobile van here, that they can first outreach to and help identify people experiencing homelessness, especially those high priority cases based on health status and high costs. They can then help connect and refer people to permanent housing, and also provide the documentation and assessment that will allow people to verify that they have the qualifying disability status to qualify for permanent supportive housing. They can also provide care coordination services, as I mentioned before, to facilitate the transition to housing, including medical respite. And last but not least, they can participate in a medical or health home to provide that wraparound care that people living in permanent supportive housing need. So with that, I wanted to just point to the United States Interagency Council on Homelessness website and to visit our toolkit. We have a number of tools and resources. And recently we launched a solutions database which contains a number of promising and evidence-informed kind of practices and programs and models that are related to the topic at hand today. And with that, I will turn this over to Joe Ferguson.
Thank you, Richard. I'll try and pick up and keep the pace moving along so we stay on track. The objectives for my discussion are going to basically deal with a brief definition of the homeless healthcare project in the homeless community, define the role as I've found it in Detroit anyway for the continuum of care in the homeless community as we find them, and define a collaborative process for integrating the CoC and HCH programs to better serve the homeless community. What is a 330H grantee? Basically, brief history is a project started Robert Wood Johnson Foundation in 1985. Our program, although we're called Advantage Health Centers at the present time, it's actually Detroit Healthcare for the Homeless doing business as Advantage Health Centers, and began in the 80s as a Robert Wood Johnson Foundation grantee and moved on to be, as I'm told, the second oldest homeless healthcare H grantee in the country after our colleagues in Chicago. Basically, the FQHC as a homeless healthcare centers are basically just like any other FQHC, although since it is a special populations designation, there are some additional requirements and advantages, particularly when it comes to the provision of substance abuse services and the sliding fee discounts being permitted down to zero amount as compared to typical CHCs or E-grantees. that are allowable to that regard. I think the challenges and uniqueness of the homeless community, the picture on the slide is of the 4 sites that Advantage operates. That is the site that sees the preponderance of our homeless population because it's located in proximity to the shelters. A lot of what Richard said about being able to go out to the sites, we find that transportation time detracts from transporting our care providers, detracts from our ability to maximize the care they can give. So we try to collaborate with our shelters to have the patients transported so we can maximize our provider time. It's one model that we use. All of our sites, all 4 of our sites, we do have homeless folks who we see at all the sites, but the Waller site is where the preponderance of the shelter patients are provided care for. The Continuum of Care role in the community, and this is just the perspective of Advantage Health Centers and Detroit. And being the only H grantee in the city when I began my role with Advantage in 2008, I really didn't come to an appreciation of where housing fit into the process of things until I'd been here for a while and resolved some of our own financial and operational concerns. But I can tell you that I have come to appreciate and hold a high regard for the role of the housing status of the population we serve. And Richard mentioned it, but one we also need to address from a FQHC homeless grantee perspective is also the behavioral health impact for this community. And so, I don't think you can solve for all things simultaneously, but you need to be aware of them and move forward organizationally. I think there is a high possibility for success the more efforts are put forward to collaborate with those in the community. One of the reasons I accepted a role with the Homeless Action Network of Detroit, the CoC here locally on the board, is so that I could not only address my concerns as a homeless grantee, but the other 6 FQHCs in the city of Detroit. And everybody takes care of homeless folks. It's just, I happen to be the one with an H grant. But we all have a homeless population that have behavioral and housing needs that need to coordinate with the CoC. And we need to understand how do we maximize those resources we have available in tight budget times. And so that's basically the effort that I see playing a role in CoC board, is to make sure that I and my colleagues are interfacing with the CoC participants in the Detroit community so that we can maximize our affiliations. I think that the challenge is that, and this is from my side of the street, is that the grantees or the participants in the CoC who are funded through that process look to the requirements of their funding requirements and don't necessarily step outside of their comfort zones to see where the healthcare grantees can collaborate with them. The automated data system that's in use, the HIM system that is used to enroll the staff, some of the smaller organizations don't see where it's important to keep the integrity of that data up. And so we're working with that and some other systems in the Detroit community to integrate some of that information so that we can better track these patients and individuals throughout the community. We have found that the homeless population may not be stable in one area. They may migrate from one area of the city to another. And an ability to track them back to a primary care source and to keep their medical records straight, and so that their continuity of care is improved, and also their support resources are stabilized also, so they don't lose track of applications and eligibility and other things. It is critical to help maximize the dollars that we have. I think that the policies and procedures that can impact this locally deals with local funding efforts and those funders and requiring those of us who are funded to collaborate and participate more closely and begin to demonstrate some success with these results. And I would take that also to a national level. There are a lot of national dollars that are attempting to chase this, and I think that Richard's presentation goes to speak to one of the several organizations that has the 10,000-foot view on this that we need to be aware of locally as well. Moving that along, I think that it's best to turn this on over to Cindy at this point and have her time for her presentation. Thank you.
Okay. Yeah. Thank you, Joseph. So thank you very much, Melissa at Healthcare for the Homeless National Council, for inviting me. My perspective is a continuum of care here centrally located in Fort Worth, Texas. We do not actually have a Healthcare for the Homeless grant, but we absolutely have a Healthcare for the Homeless task force. And my introduction to the resources in the National Council was a good old emails and Google searches, and found an extraordinary amount of information, research, and studies to support the work of our Healthcare for the Homeless task force in making sure that we address the behavioral health, mental health, and primary care and emergency care for our homeless. And so that resource, and going to 2 or 3 of the conferences now, has really been beneficial. And so I'm kind of going to talk about, now that we have all these challenges presented by Richard and Joseph and the continuum of care, in effect, I've got to figure out how to, as a leader, take all those challenges and make something happen successfully on the ground. Traditionally, people would say, what's the continuum of care? Oh, yeah, you're that grant. You're the housing. And so we absolutely are, as Richard has described, this group of stakeholders. But there's the grant, and now increasingly there is this continuum of care, the system. And so in that system, I am responsible for sort of tracking and managing this whole community and conversation, providing a lot of data and information that hopefully we will convert to knowledge and solutions for the varying barriers that were mentioned, and then sort of managing the delivery and the quality of the services, dealing with complaints from a homeless individual to a complaint from a recipient to different things, and trying to resolve communication between agencies and providers on the ground as part of that system. This is just sort of a component of the kind of the traditional continuum care system. We do prevention efforts, supportive service, emergency, the transitional housing, of course, permanent housing. But we all know that in reality, when we look at a continuum of care system, there's purportedly no wrong door, lots of communication, interaction, phone calls, emails, and hopefully we're not sending our clients from A to B and back to C and to A, that we have actually a relatively coordinated care that makes all this not look so chaotic. That's part of those challenges of our continuum care system. It's no longer just about that housing grant anymore. It's real in-depth coordination and continuity of the care. When I try to describe how we can have all this work together, we've got CoC, the Continuum of Care, that grant writing entity, that lead agency. And then, of course, we have all of our funders, both public and private and faith-based, that we have to address their goals, their needs, their reporting. And then all the service providers who feel challenged by the different reports that a continuum care lead agent requires and all the grant requirements of private funders, yet they're trying to keep their feet on the ground and end homelessness. But so I'm that lead agency. Many of you who are listening today are those homeless service providers, healthcare for the homeless entities, and then there's HUD and HHS and the VA and all those other private entities. And as we step forward, we have opening doors in this plan. We know very well that we all have to work as a system rather than handing a client off to each individual entity, because we all have this goal of preventing and ending homelessness that is so well stated, that Richard presented in that plan, and those very, very specific objectives within the National Opening Doors Plan that address the relationship between healthcare and health stability. So who is your continuum care lead agency? I've got here that Homeless Resource Exchange link, very easy to find, because I didn't know who my HCH or HRSA grantees were in my community until a year or two ago, and found out I had an FQHC, and I did the same thing by going and looking and Google searching. The same thing can be done here with the Homeless Resource Exchange, and then find your state, find that map. And here specifically, I'm in Texas. The continuing care maps, they have a year. It's the latest is 2011. Those 2012 data sets are soon to come as HUD and the SNAP's office are plowing through and evaluating the continuing care grants that were submitted on January 18th. And you can easily find the contact information that's updated quite regularly. And there I am, right there. You all can call me. There's my cell phone number. Some people may not see a specific geographic area because in some parts of the United States, you're covered under what they may call a balance of state, everything that's not in a particular urban or suburban core. And then there may be a balance of state. And, of course, the SNAP's office and others would be quite willing to help you find where to go to. So here I am. I'm a lead agency. I'm the Tarrant County Homeless Coalition, a 501c3. Been writing the grant for 6 years. I have a mission to lead and coordinate and develop strategies and resources to end homelessness. And very specifically, 2 years ago, we did some strategic planning. Knowing the HEARTH Act was out May 2009, awaiting the interim rule, very much want to be a team player, that we're looking to be that lead organization that provides not just write the grant, but information, education, training, and planning that where we are aligned with that federal opening doors plan, aligned with our own state interagency council, and our own individual local goals to end homelessness. And so we think of those real traditional roles that many of you may be familiar with, what that continuum of care does. In fact, the first thing, that housing inventory chart, letting the community know the housing we had funding for, what do we still have available. In fact, that's due at 8 o'clock today, so when I get off here, I'm going back to finish that. And then that point-in-time count every last 10 days of January every year. Many of you may be part of that process and have participated and volunteered. Letting the community know the nature and extent of homelessness year to year, looking at that data, what services do we need, what do we need to prioritize, that supply versus demand. Then we have to develop this annual plan, and all this data kind of goes into that big grant that we submit. In my community, it's just over $12 million. The majority, of course, increasingly is housing. So that's the grant. It's in the SNAP's office, 1.6 in 2012, and as you know from sequester, it's getting reduced, and in 2013, we're going to have less funds, not enough to fund the renewals, which means continuum of care across the nation are going to have to really look to their continuum of care to say what are those absolute needs, because things are changing. That's that HEARTH Act and that interim rule. And so not only is that continuum of care just writing that grant, we're not just bona fide, I like to say, being a submitter, but we're codified. It is now a federal requirement. And so in addition to the HEARTH, we fine-tuned that definition of homelessness here, those 4 categories, and those specific programs funded by HUD under what eligibility definition. Those continuum of cares are critical for that eligibility to be able to assist agencies to document. And they've got very specific measures. Reduce the number of persons experiencing homelessness, their length of stay, and make sure they don't fall back into homelessness. And all those measures, we have to set strategies to meet. When you look at all of the different national objectives that drive the continuum of care strategies and policies and the work plans, it's not just about the opening doors, how to create new permanent housing for the chronic. And then when you get into stability in housing and moving from transitional to permanent, getting people jobs, reducing households with homelessness, attaching to mainstream benefits, think of all the barriers about that and how much of that is related to behavioral health, substance abuse, not having primary care, frequent use of 911 as opposed to having a medical home. There is no way for a continuum of care to effectively address and produce good local strategies without working directly with healthcare providers. That's why under the Hearth Act, when they codified the continuum of care, they literally said, okay, now we've got a guidebook and a workbook for you, and you need to go identify representatives to serve on your continuum of care board that not only just represent the providers and the housing providers, but the victim service. You need to have faith-based. You're going to have to get the government folks on board that have the emergency solutions grant, public housing, your independent school districts, and yes, hospitals, healthcare, mental health care, substance abuse care, all of those categories that fall within the subpopulations. You have to go through and look and find those leaders in your community. And so many communities, continuums of care right now, under that interim rule, we have until August of 2014, 2 years to do this, to look at our existing continuum care board and get in effect, compliance. So you have continuums of care. I know Dallas, myself, are looking to put that together. And the CoC board has now very codified responsibilities. You have to operate the continuum of care, that year-round planning, all those federal requirements, monitoring, evaluating. You've got to designate and reevaluate your HMIS. Is it going to meet the needs of performance measurement? And are you going to be able to have an HMIS system that easily shares data to healthcare providers, mental health providers, and substance abuse providers to provide that continuity of care, and someone to do the CoC, all that year-round planning. In order to do this well, we have to have a very inclusive board. And there's very specific requirements that HUD has absolutely outlined within this, that you have to meet at least twice a year. And to get this kind of work done, we know in our community we're going to be meeting probably 6 times a year at least, with a high emphasis in the fall of each year after the NOFA comes out. You have to do a call for members once a year. We have to write down the processes on how we're going to select that board, how we're going to elect, how we're going to operate. We have to appoint the committees and task force as needed. Without question, my Healthcare for the Homeless Task Force is going to have almost a standing committee because of the impact that has on the number of homelessness, length of stay, and recidivism in homelessness. We have to have a charter that details our responsibility, and we have to show that we are representing all the key subpopulations that are indicative of our particular homeless population. So we have this new governance and structure that we have to put together. We're, about a year and a half out from that deadline, and in my community, we're doing it now. So we get all the bugs out before we have to formally present to HUD through our Continuum of Care grant. In my community, like many communities, and I know it's also that way in Dallas, is that I was a 501c3. I was writing a grant, and many of my board members were actually Continuum of Care grantees that now within the interim rule, I may have to monitor and evaluate. So clearly, because of conflict of interest, they need to be moved off my board, because now we have a very different, almost a contractual relationship. If I am named the CoC lead agency, I need this larger umbrella board that is a vision and a planning for the solutions of homelessness in my community, and I need to provide that operations. So there has to be a separation, quite literally, so that I'm not evaluating and monitoring a program that's being funded for the continuum of care by someone who also may happen to be maybe the person who has to evaluate my performance as an executive director. And so it's going to be also helping to legitimize the role of this continuum care board to my community. So that arm's length is very important to separate the big picture from the collaborative applicant, the CoC lead agency that actually writes that big grant and hits submit. So this is kind of giving you just an idea of the structure of the way we were. I have this Tarrant County Homeless Coalition, my board of directors, some of them who are grantees, who also, they also served as my Continuum of Care board. And now we are in that process of change. And so this is our new kind of community, how we're looking at our org chart. We have the CoC board that has all those components within the guidelines. They have a job there in the blue box. They need to name the CoC lead agency. They need to name the HMIS lead agency, and they have to approve that CoC grant, that it matches the community priorities. And so we have put together and passed just last month an actual charter that is literally starting tonight and over the next few weeks being through resolution at the City of Fort Worth, the City of Arlington, Tarrant County Government, Parker County Government are going to, by resolution, approve and recognize this charter for the Continuum of Care Board. And then when that board comes on board, we're actually also actively seeking nominations. We will be on board, have our retreat, and ready to go to work September 1, hopefully prior to the next notice of funding availability for the Continuum of Care grant. And so that's where we are. And in that charter that we put together, we very specifically say we must have a representative from health care providers. And that is actually within our charter, and we targeted our application for board. I now know that my public hospital has identified who is the decision maker, the person who has the capacity to change policy, the person who has access to data information, who can be a change agent within county hospital, is going to be applying to be on that board. The key person in the EMS facility, key person within the mental health community. That highest level of decision makers and community leaders are going to be on my board. And so when we're also looking at as a nominating committee, literally Continuums of Care around the country are going, okay, who do we need, who do we have, and make sure that we target that so that we can address all of those challenges, working together as one system of care within the community. And one of the things that I would also talk about in looking at that, let me go back real quick, when we talked about data, and one of the key roles is that many continuum care lead agencies are also HMIS lead agencies, that is the case, and dealing with the sharing of data and information. Though I can't see hospital data because of HIPAA data, we've absolutely opened the door and trained clinic staff, EMS staff, and mental health, the mental health psychiatric ward staff to access HMIS, and encouraging them that if they have a patient, ask them for authorization to share the information upon discharge with case managers. And so that's one of those key roles, the integration and things that can happen, the identification of the medically vulnerable because of the shared information, our ability to break down many, many barriers in relationship to medication management for those individuals with mental illness and those things. The dialogue from a good old general case manager who is funded through Continuum Care with the actual clinicians and practitioners is critical and important. So what can you do as someone who may or may not really be that integrated and thought Continuum Care is that agency that just writes a grant or has the housing? Go identify the Continuum Care lead agency in your community because they're undergoing a dramatic change right now. Start attending whatever meetings that they have. They are to be public, and increasingly there need to be posting agendas in a public place, and they must also include a component of public comment. You know, get involved. Ask when the next annual call for membership to that Continuum Care Board is in compliance with that interim rule. And if you're a continuum of care or coming from that community, identify those change agents within, you know, mental health care, primary care, behavioral health care that really you believe need to be on that CoC board to bring about the kind of communication that you all want to be very effective. And so that's my that's where I am right now in the middle of everything in my community. And there's always a million hats going on. So I'll hand it over to you, Melissa. Thank you.
Thank you so much. Richard of the U.S. Interagency Council on Homelessness, Joe Ferguson of the Detroit HCH Advantage Health Systems, and Ms. Cindy Crain of the Tarrant County CoC in Texas. That was an incredible presentation on HCH and CoC collaborations. We do not currently have any questions from our participants, but I do see that there are a large number of healthcare for the homeless providers represented. So I wonder if I might call on Joe to maybe share with us a little bit about his experience and or maybe motivations for engaging with his CoC in Detroit. Joe?
Sure, Melissa. I mean, probably, I'll have to be, I wouldn't be anything other than honest, but I have a board president who is actively engaged in the housing community and has constantly been after me to cite some facilities and resources in some of the housing programs in the city. And so basically, before capitulating entirely to his desires, as well as working with the National Healthcare for the Homeless Council, I decided to work get a little bit more involved to see exactly how the CoC was allocating resources and what might be the best approach to integrate our services with the housing community, which has led me to attend a couple of CoC meetings and then be invited to sit on the board there. And the leadership, as Cindy points out, some of these changing responsibilities for CoCs has led the local HAND organization to move more from a kind of what I would consider just a membership association for the local HUD-funded entities in the community to more of that lead CoC agency and begin to seek more collaboration and add members from the community. So, and I also find when I go there that they've strengthened the behavioral providers. I think there's a little bit more that can be done to add some health systems providers to the CoC. The folks that really have the most at stake from the healthcare resource standpoint are the health systems. And in large urban areas where there are multiple or two or three large health systems, if they're not going to take an opportunity to come into something like the CoC and help address some of the common needs for the homeless community and work with other funded health providers such as the FQHCs, whether they be homeless grantees or not, I think they're missing an opportunity to really sit at the table and solve some of these high-cost users of the system. So I think, well, I don't think that's my desire to become involved is, to basically see that we are looking at frequent users of high-cost services and how we can coordinate some of those efforts to do supportive and permanent housing, to get the behavioral services, and to keep track of these folks so that we're getting them back to where they need to be when their lifestyles take them from one part of our geography to another. So altruistic at this point, but we're trying to put some measurable objectives together with HAND and our other community mental health providers and health systems to try and put some systems to this process.
Thank you so much, Joe. I really appreciated your elaborating on that response and for allowing me to put you on the spot. We have a couple of questions. They're more logistics. I just want to respond for everyone that on the nhchc.org website, we do have a directory of healthcare for the homeless projects across the country. And there is a question that just came in, and I think I may not be understanding the question, and it's possible that it's for Cindy. Shireen asked, how can some of this be done for a statewide CoC? And so, Cindy, I guess maybe my confusion is the part about statewide CoC, and maybe maybe Shireen can elaborate a little bit as well on her question.
Yeah, because if it's a teeny tiny state that just has one continuum of care, that would be it'd be very difficult. Like our balanced state in the state of Texas, most of the key metropolitan areas have their own continuum of care, and those rural areas, far west Texas, east Texas, are managed where the statewide CoC pretty much just manages an HMIS system where they all contribute to, and very difficult. But within a you were going to have in your local community. I didn't have a HCH, despite everything. There was still a need for this continuum of care to pull together the EMS provider and the county hospital and all of the clinics together and say, you all are dealing with your same high system utilizers. You need my help because I am the expert on homelessness. You're on the expert of providing emergency care for the homeless, and we want to convert that to primary care. And so I think that really has to be done almost at that county level, however your community is designed to develop that system of care and have that, and have that communication with your emergency shelters or your street outreach teams. In my community, I wanted to mention that how we sort of evolved into this was just literally my moving my office to a day shelter and watching what we have MedStar here is our EMS provider pull up under my window 10, 20 times a day. And I said, okay, this is crazy. They agreed, and they developed a community program for high system utilizers for everyone who was homeless. Or for everyone except who were homeless. And I said, why not the homeless? And now 50% of that program are homeless individuals and massive reductions in 911 calls because of our communication. And now they have individuals who they know the homeless very well, and now they understand our system of care and the ability to take care of things before it gets to an emergency or a real high acuity level. So I guess if I knew her specific state or what it looks like, then I might be able to be more helpful.
Thank you very much, Cindy. And I think, Shireen, you have an invitation then to follow up with a question that we'll probably respond to by email. So in our last 9 minutes or so, I think, let's see, I'll invite Richard. Do you have maybe any closing thoughts for our participants today or any notes of encouragement for the CoC-HCH collaboration endeavor?
I mean, I think a lot was covered. I think this is a really important topic, and I really appreciate the National Healthcare for the Homeless Council for putting this on. I think there's been some promising things that I've just heard from both Joe and Cindy about some of the work that's happening, really being driven by the health system in the focus on people who are high utilizers and high-cost individuals. I think one of the things that we didn't maybe touch on enough is around the Affordable Care Act and some of the health reforms that are happening both around Medicaid expansion in the states that are opting to do so, as well as around some of these new care delivery vehicles that are really looking at how we can use kind of Medicaid as a kind of entitlement source to really pay for much more coordinated kinds of care. And there's been a big focus, I think, on how we can use those care delivery vehicles to really drive down costs and improve care for people who have the most severe challenges. And as many of you know, people experiencing homelessness are among some of the most complex and high need and high cost individuals. And so I think there's a natural opportunity for those of us who work in homelessness to really bring that information and data to health systems as health reforms are happening, to say that there needs to be a focus on people experiencing homelessness to the extent that they overlap with some of the high need, high cost beneficiaries that the health system's thinking about changing the way we deliver care. And that really looking at how those opportunities in new care delivery vehicles can really create an opportunity for how we can provide the kind of comprehensive package of care that we've all been striving towards to help end homelessness.
Thank you, Richard, and thank you also for the suggestion for a follow-up webinar topic. I wonder if I can invite Joe and Cindy, Joe next, maybe for some closing thoughts.
I had to find the mute button. I think just in closing, I think it just the whole process of Richard and Cindy's and the council's comments just points to the fact that there's a lot of need in communities across the country to continue to collaborate and work together to solve these issues that affect the homeless community and those in poverty altogether, which are housing and behavioral health and access to primary care. So I think that that would be my closing thoughts is for all participants to continue to find ways to work together to maximize resources to address the needs of this population.
Thank you, Joe. And Cindy, maybe a 30-second closing thought?
Sure. I think that bringing on healthcare providers, if you're a continued care is getting increasingly easy because of their pressure to reduce readmissions into their facilities. And Texas, of course, is an opt-out as what we believe, but we have some exciting opportunities as we await the 1115 waiver program, Medicaid, where my community put together a pretty substantial homeless initiative. My closing note is that, we have the NEH, the National Alliance to End Homelessness Conference, every year, and I started going to the Healthcare for the Homeless National Symposiums, and both of those are such a great 1-2 for Continuums of Care and Healthcare for the Homeless providers to go to, because and I guess it's May of 2014 in New Orleans, the next HCH, and I'm trying to get my clinicians and everyone together. It's not just for HCH HRSA grantees and just the ideas that are generated from around the United States. We are not, your community is not the only one having to deal with these issues, and it is an extraordinary resource. Go ahead and give a plug, because I'm trying to get a good group of my local folks to go next year, because it's just so many ideas and ways to solve problems, and no reinventing the wheels. And so I hope everyone kind of look at that, because you're all doing your budgets for 2014, and travel's pretty tough. But what I've gotten out of it, and I think others will get out of it, are pretty extraordinary, to be able to meet these metrics and these performance measures that HUD and HHS and other funders are looking for in the future.
Thank you so much, Cindy. Thank you, Richard, Joe, and Cindy. And Cindy, especially for that plug, because my next slide, actually, or 2 slides from now, I was going to introduce, well, actually I still will. I'm introducing Wade Mundy of our ROC and TA and training team to talk a little bit about upcoming events.
Thank you, Melissa, and thank you, everyone, for your participation today. The National Healthcare for the Homeless Council exists as a membership organization in the same way you seek to provide a clear path for patients from the streets to housing. The Council exists as a membership organization to help you navigate the complexities of public policy, to provide you with updated clinical guidelines for medical respite providers, primary care physicians, and other providers. So, Cindy, you did a great job of plugging our upcoming trainings, which is where you can fully experience the range of subjects that we explore in live conferences and trainings. Up next, May 9th and 10th, we'll be in Morristown, New Jersey, and there's still time to register for that live training in Morristown, New Jersey. The cost is $45. New members receive a special discount for all of their providers at their locations, and hopefully we can put you in touch either at this regional training or at any number of our future conferences, trainings, and webinars with your local community or with people around the country who are experiencing some of the same things you're doing. You're welcome to contact us at any time by looking at our staff page on the website. Anything that you have questions about regarding this webinar, upcoming trainings, or simple technical assistance questions related to the confusing acronyms you might experience on a daily basis, we're happy to help sort you through that. So thank you again.
Thank you, Wade. Thank you again, presenters. Thank you, participants. And just a quick clarification, we have an upcoming regional training in May in New Jersey, and then next May 2014, our national conference in New Orleans. More on both of those on our website at www.nhchc.org. So again, thank you all so much for participating today. Please take our survey as you exit so that we may improve on our webinar content and delivery. Wishes for a fantastic rest of the week.